Hi, everyone. Thanks for tuning in today, and we'll probably have some additional viewers. And one thing I'll say about COVID-19 is, whatever you say today is outdated the very next day, because this is probably the fastest moving amount of information that we've ever been faced with. The entire globe is working on this right now. Every, scientists are directing a lot of energy towards this. So this will be old news tomorrow, but there are some really important messages that I want to get to you guys, especially with the holidays coming. So without further ado, we are going to talk about sort of what's new from last time. I'm going to just hit on kind of a smattering of hot topics and questions that we tend to get a lot to kind of give you my take on what's out there. We'll go through what we know about masks, and then we will then delve into what's happening in the United States right now, particularly in the Midwest and in particular Minnesota. I will give you a window into what is happening in the hospital right now. I just came off of hospital service on Friday, and I'm doing a COVID shift. I came off of hospital service last Friday, and I'm doing a COVID shift this coming Friday, and I've been in a number of meetings, so I can give you a window into what is actually happening in Minnesota right now that's not really making it into the news, frankly, because I think you need to know. And I'll talk about how you can keep you and your family safe. And then also just a refresher on where to go for accurate information, because in this age of constant news and information that's out there, it can be really overwhelming about where to find truth. And I want to empower you guys to find information that is accurate. So there's a lot that's new since last time, and we're certainly not going to hit on every component. And also keep in mind, I'm a cardiologist and not an infectious disease specialist. I have advanced degree in sort of clinical research and public health, and I'm quite good at statistics, which helps me in my career. But again, I am not an actual infectious disease specialist, but I will tell you what I know and sort of the highlights. So we talked last time about something called the case fatality rate. And remember, in order for us to know how many people with this disease die, we have to know the number of people that die from the disease over the number of people who have the disease. And of course, in the beginning, we didn't have nearly enough tests to know how many people actually had the disease. And so, that denominator, or the bottom number, whenever you're doing simple math, number of people dead over number of people with the disease, there's a lot of factors that go into that. In the beginning, we didn't have enough testing. I do think globally we are better at treating COVID-19 than we were before. So if you look at the case fatality rates early in Italy and in Wuhan, and then you look across the United States, there was certainly a decrease in mortality from this disease, which everyone said, my goodness, this is great information. We are better at treating it. We know that early steroids for patients with moderate to severe disease likely helps significantly. We are putting patients on blood thinners with moderate to severe disease to prevent clotting in the blood vessels to the lungs and stroke and heart attack, because this disease can cause clotting. We are better at ventilator strategies. And of course, there's a lot of things in the news about certain antivirals and plasma and antibodies. There's a lot of treatments. Really, we think steroids has probably been the most effective. So I do think that we're better at treating this disease than we were at the beginning, because we are sharing information. So that's part of the reason the mortality has decreased. We also know that younger people have been infected. In the beginning, when this was ravaging nursing homes, and those patients die at very high rates early in the pandemic. When you have a lot of college students, et cetera, getting the disease, the mortality is going to go down because you have a younger population that's infected. And of course, that denominator, meaning if we have a lot more tests that we're running and we're able to see like how wide the infection is spread, that also decreases your what's called the case fatality rate. So no doubt, we think the mortality from this disease has gone down, at least through the summer and early fall months. And one other thing that I want to point out is I think we have more and more evidence as time goes on that masks, in fact, decrease the amount of viral exposure. And I'll go over some data to support that, but this is true in many other virus transmission models and also in animal models of the coronavirus as well, that the amount of virus that you get when you get infected is likely very important in determining the severity of your illness. So for example, in Wuhan and in Italy, when you had ear, nose, and throat doctors and respiratory therapists or anesthesiologists, we saw a lot of deaths in those healthcare providers early on. And now that we are masking everyone in the healthcare setting, we are seeing that a lot more. So a bit more on that in a few slides. What we don't know, we don't really know how long immunity will last, although people who are infectious disease and immunology experts do feel that the fact that we haven't seen a lot of second infections, there have been a handful of case reports of people who appear to be infected more than once, but it's not on the order of magnitude that we would expect if this virus really hit you again. And so we do think that there is some immunity to this virus from having it before, but how long it will last is unclear. We know that the virus has some mutations. How meaningful that will be in terms of controlling the pandemic in the future is not quite known. We also are still in the early phases of understanding the long-term ramifications of the virus. Many of you have heard, reports of people with symptoms that linger month, 2 or 3 afterwards, or those who have kind of permanent, a severe course, but end up having permanent lung damage or scarring on the heart. We are still finding out the impact of that, and I can tell you firsthand, we are seeing a number of patients who have very severe lung damage from this disease that will be with them likely for life. And also, I would just say the true safety of many activities is not entirely known. We know where transmission is likely to happen, and we can go over some of those events, but there's a lot of data out there in the business world trying to encourage everyone to do things that are safe when there's probably inadequate evidence to support that. So many of you probably heard earlier this week, there's a vaccine. Pfizer releases, the early data on the human clinical trial showing 90% effective. I feel encouraged by this news as well. I'm excited. My goodness, this means that we are moving very, very quickly, that we may have, in the logistics of getting a vaccine, to the population, not only in the United States, but globally is really mind-boggling, but plans are being made. So I think there's reason for hope, but I would also caution that there's more safety data that we need, and also the 90% effective. Is it 90% effective at preventing a cough and a fever, or is it 90% effective at preventing severe disease? And we don't really know that yet. And so I feel encouraged with this also, but there's still more. This is not yet peer reviewed. And so I think it gives me some hope and optimism, but it's not going to be here to save us from the trajectory that we're currently on through the next several months. And this does not mean we're ready to throw caution into the wind just yet. I think it's reason for hope, but we still need more time. The whole—
Can I take the opportunity to ask you a question there?
Yeah.
It's one that came in. Could you shed a little light on what potentially, whether it's the Pfizer or another vaccine, what rollout might actually look like for our community in particular, the transplant, LVAD, heart failure community?
Yeah, I don't know yet, honestly. So like, I know that there are, sorry, I'm getting a page from the cath lab. So I don't know enough details on which vaccine maker. I know that there are plans being put into place with vaccine committees, and I know, Biden is rapidly assembling a team to figure this out. I am getting questions about, whether transplant patients would get it first, whether LVAD patients would get it first. It's too early for me to comment on how that's going to look just yet.
Okay, follow up to that then while we're on the topic. The type of vaccine we're talking about, knowing that those that in transplant and immunocompromised typically couldn't have a live virus type of vaccine. Curious, because the nature of the Pfizer vaccine in particular has to be stored at what is about a negative 100 degrees roughly Fahrenheit, I believe.
Yeah.
Does that imply that it's a living virus vaccine, or can you shed any light?
And I'm going to have to defer on that. That's beyond my knowledge and scope to know exactly how the transplant community is going to deal with this virus. I just don't know the answer to that.
Okay.
From a herd immunity perspective, we talked about this last time, the whole concept of this is what happens with things like measles and mumps. If enough of a population is vaccinated, a virus kind of can't take hold and spread throughout the community. That's the concept of herd immunity. And in order for that to happen, you need to have enough of the population, albeit 60 to 80% have had exposure and recovered or have been adequately vaccinated. As of 9/25, 90% of Americans, when they looked at surveillance of various communities, to see how much of the population was still vulnerable to the virus. Like, we're talking about 90% of the population. And even though we just had 1 million cases last week, keep in mind there's 130 million Americans. And so it is the number of dead bodies that will be occurring if we go for herd immunity before we get to a vaccine will just be catastrophic. And so, you know, in order to get that number of people immune, the number of infections would lead to so many deaths, it's hard to even get your brain around that. And Glenn, I can certainly find out on more follow-up, you know, as disclosure, I know what I know, but I know the extent of what I don't know, and I can find out more vaccine information and follow up with you guys about that.
Thank you.
From an airplane travel perspective, everyone got all excited about this study that was published and about how only 44 cases occurred in 1.2 billion passengers. This is the most completely ridiculous study I have ever seen. I don't know how it made it into a medical journal. Literally, the International Air Transplant Association, which represented 290 airline carriers, looked in the medical literature and said, wait a minute, we only see 44 cases linked to a flight. We know that 1.2 billion passengers traveled. Let's use that as the rate of transmission on an airplane. This is completely and utterly ridiculous. This is not fact. These patients are not being tracked. And so, you know, in order for you to really know, yes, masks we think help. Yes, maybe there's HEPA filters on, but I would say the jury, public health officials feel that the jury is still out in terms of how safe airline travel is. In order for us to really know, you would have to track people, you would have to do viral testing. None of these people have been contact traced, and they're also on the move and going different places. This is not evidence of airplane safety. I will tell you, I flew once during the pandemic to Sioux Falls, and I talked to Glenn about this. They, on a 25-minute flight to Sioux Falls, served Cheez-Its, 2 granola bars, and a water bottle. And every person in front, into the side, and the back of me had their mask down for 20 minutes out of the 25-minute flight. And they were inches from my face. And so I would tell you, the airline industry published this study. Okay, so that should tell you. So yes, N95 mask if you sort of have to do it, but the issue is right now the community prevalence of this disease is so incredibly high that when you are getting on an airplane, you are getting on an airplane with coronavirus teeming everywhere. And so it's very different than maybe early summer when the caseload did not look like it is. The entire Midwest is a red zone right now. And so I would caution that we still need more time to understand, and it would be nice to have some evidence not supplied by the airline industry to understand what the safety is. And there have 100% been transmissions reported related to airplane travel and proximity to people around positive cases.
Yeah, anecdotally on that point, anyone can look this up. It was reported 2 weeks ago, a flight into Ireland, and I believe originated in the US. There were 49 confirmed cases that came directly from that flight into Ireland. Isn't it one example?
Just as one example. Okay, so I don't think it was 44 cases out of 1.2 billion. I think that seems like maybe a stretch. So from a transplant, you know, how do transplant patients do with this? I would love to tell you that I have a ton more data than we had initially. There are some registries being formed, and I think anecdotally among those of us who are transplant physicians in the community, we are feeling that probably our patients are doing a little bit better than they were reported initially in New York. But as of right now, for published reports, the ones out of Italy and New York are some of the only ones that are in the actual medical literature, which are looking more like 22 to 25% mortality. I think we do feel that it's going to be less than that. I can't divulge how many cases we've had out of our 390 patients at the University of Minnesota, but I will tell you of the positive cases we've had, half have required hospitalization and some are having long-term consequences. So I'm not going to give more details than that because you guys all know each other too much, but of the cases that we've had, half have required hospitalization for the disease. So I want to talk a little bit about masks and what we know about masks. Part of the reason this pandemic is so unbelievably hard to control is the concept of asymptomatic spread. And I know you guys have thought about this. At this point, if coronavirus was an illness where you didn't actually have virus coming out of your, when you were talking or breathing or coughing, until you actually had a fever or a cough, this would be an entirely different story. But the deal with this virus is that some people have the virus and don't even know it. And secondly, even if they are going to get symptoms, they spread virus before they even know they have it. So even a well-intentioned person who feels quite well could be infecting others. This is why masks are so incredibly important. The concept here is to reduce transmission, but there's also a concept here of reducing the severity. We are seeing that, nurses who are getting exposure through their mask are getting a milder course or more likely to have an asymptomatic infection, which is sort of a poor man's vaccine, and not the way we're suggesting that people become immune. But we think that it does two things, reducing transmission as well as the amount of exposure. And so we really do believe that masks go both ways. We think it protects the wearer from getting virus, a high viral load breathed onto them, but we also think that it prevents transmission from people who have the virus but don't yet know that they have the virus. And that's been confirmed in many, there's a lot of evidence to suggest this before. And so, yeah.
Yeah, and one note, are all masks created equal? And I don't mean the N95 either, but kind of everything else. What's your point of view on some of those?
Let me go through the next 3 mask slides and then we'll circle back to the type of masks. But in general, when you look at mask mandates, we know that mask mandates across counties, and there's different, we know that there's N95s and surgical masks and cloth masks with different ply. But in general, there's a broad use of masks of all different varieties being used in the community. And what we know is that when mask mandates happen in communities, we see the virus counts go down. So I'll show a next couple slides and then we'll come back to the different type of masks. But so in Kansas, for example, the governor required a mask mandate, and the University of Kansas ran this analysis. So certain counties agreed to comply with this and certain counties didn't. But you can see in the let's see, sort of in the tan here. So this is when the mask mandate. So the counties that actually complied with the mask mandate, their infection rates went down dramatically. And those that didn't, it did not dent. This is a really nice visual published in the Washington Post using this thing called Covidcast data. So this is a number of people who have symptoms over here versus the percentage of people that mask all the time. So you can see in the Northeast where masks are worn almost 100% of the time, the percent of people with COVID symptoms is extremely low. And in places like South Dakota and North Dakota and Iowa and Wisconsin, where masks are worn, like around only 60% of the time, you have a dramatic, like this is a linear association. So less mask wearing equals more infections. And this is a study across, this is from Monica Gandhi, who's a public health and infectious disease researcher at UCSF, where I trained. They did an oh, we're having a battery issue. Hold on.
Okay.
Hold on.
Go ahead, take care of that.
So there's 100,000 counties. Or sorry, 1,000 counties with mask mandates. Just grab this.
Yes, and as you can see, I don't know, is there a bad joke here about recharging your battery even in COVID?
There's well, anyway, so there's a hospital. This is hospitalizations, and this is another thing that gets down to that in the severity of infection based on the viral load. This is hospitalizations do not lie. People will say, oh, well, the rates of cases are going up in the community because we're testing more, which is totally insane because you can look at the percent positivity, but hospitalizations do not lie. In counties that complied with mask mandates, at the time of the mask mandate, the hospitalizations in those counties continued to fall. Hospitalizations, that's really, really hard evidence. And so that gets to your point, Glenn, about, should we be using surgical masks? Should we be using N95? Should we be using cloth? I'll tell you, in the hospital, we are using surgical masks pretty much for all non-aerosolizing procedures, and we are using N95s only for procedures where we're having to intubate or having high flow oxygen that is kind of blowing that into the air. And we're also using HEPA filters as much as possible in the COVID positive rooms. But this would sort of suggest, and there's a New York Times a visual of like a surgical versus a cloth versus an N95 in terms of the number of particles that are sort of caught, viral particles that are caught with each of these components. But this would suggest to me that masking of any type. So there's, and then you guys as transplant patients really want to protect yourself. And I do think we have some evidence that N95 is better than surgical, which is better than cloth. But masking of any type on both parties is very effective at community transmission, preventing community transmission, if that makes sense. So let's talk about some really disturbing trends here. So in the United States, this is from the New York Times, this is just from yesterday. You can see we sort of had this first peak followed by the second peak, and now we are in the dreaded and well-anticipated fall surge, which is this general concept that you have enough of a hold of the virus in the community, and then the coronavirus fatigue of just separating, everyone just is tired of it, in addition to the fact that the cold has come and the heat has turned on, and the door shut and people come together and the cases just take off. And this is exactly what we are seeing in the United States. So just yesterday, there were over 130,000 cases. And according to Michael Osterholm, who's a University of Minnesota researcher and public health and infectious disease specialist who is frequently cited in the New York Times and has just been appointed to Biden's staff, the way that this is going in the next month or two, we're going to be looking back and wishing for 130,000 cases per day. And we've had over 1 million cases in the last week. When you look at Minnesota in particular, you can kind of see this, this is a very, very different looking curve than we had before. And this growth it's hard to really even put it on a scale. For those of you who are scientists in the group, this almost belongs on a logarithmic scale and not a straight linear scale. It is literally, the line is basically straight up. And again, this concept of, oh, well, maybe we're running more tests. Absolutely not. The percent positivity does not lie. And this is of the people who get tested, the percent that turn positive. Places that have control over the pandemic have percent positivity rates, meaning of all the coronavirus tests that are run, of less than 1%. When you have that kind of control in your community, you can find those little pockets and then kind of lock that little area down. This is just like the wheels have come off here. What about hospitalizations in Minnesota? And for those of us who are in the field and those of us who are living in the hospital and taking care of patients every day and trying to keep not only our families safe and our colleagues safe, but the patients that we serve. And, when I think about all of you guys out there, my job is to make sure that people, people's hearts last as long as they can, that we get them safely through their VAD or transplant, and also that VAD or transplant that they have on the other side, that they're not going to die of this afterwards. I'm trying to keep you guys all safe. And for me to do my job, I have to have hospital beds, and I need you guys to stay out of them and stay out of here. But this kind of up, where's the end, guys? So this kind of increase, we already have a masking mandate in Minnesota. Even if we were to all sit on our bottoms, every single person, shelter in place, no businesses open for the next 3 weeks, the die is cast on the next 3 weeks. We're going to continue to go up because all of the households that have this, it spreads in those households. And so we are literally going to see this continue to go up no matter what happens at Thanksgiving. We are going to continue to see this go up. And so you're probably wondering what's happening in the hospital right now. Well, this really hasn't made it into the news yet, but I'm just going to break this down for you right now. We can't transfer patients in. We have patients waiting in the wings. North Dakota, South Dakota, northern Minnesota, across town, we can't get them in. And sometimes that happens on a normal day where we kind of move things around and maybe we can sort of get people in. Nope, not right now. I've got transplant patients up in Duluth. We can't get them in. And for those who need a balloon pump or a transplant or a temporary support device, they will die where they are. On Thursday, overcrowding in the ER doc, they had a patient collapse from a GI bleed in the lobby who was inappropriately triaged because they were so slammed with all the overflow from the inpatient and beds stacked up everywhere. Patient collapsed in the lobby who was inappropriately triaged because there was no staff. Last Thursday morning, I got off the phone with bed control in charge of the entire state. They had 100 calls in under 2 hours trying to place patients. St. Cloud has shut down all elective procedures and surgeries, and it's been that way for close to 2 weeks. As of Thursday last week, November, we had 2 staffed ICU beds in the entire state. 2. You might be hearing well-intentioned plans for, we're going to increase beds, we have ventilators. Guys, if we don't have staff, we don't have beds. North Dakota just sent COVID positive nurses into work because it's so dire. And guess what? There's no surge nurses to hire from any other place because every place is surging. 28 out of the 40 medications that we absolutely need to keep people safe in the ICU, all the medications for sedation, all that stuff, are on global shortage. Europe needs them, we need them. This happened in New York. They ran out of everything. They were using crazy meds to try to keep people sedated on ventilators, and staff are being actively repurposed into jobs that they're not qualified. Well, they're training, but it's not exactly who you'd want taking care of you. So, and I'm not talking about 3 weeks from now. I'm talking about now. And the curve looks like this. The survival of COVID-19 is 100% contingent on you having access to the medical care that you need. In areas that are overwhelmed, the mortality from this disease skyrockets. Yes, the mortality went down over the summer. We had enough beds, we had enough ventilators, we had enough critical care specialists and respiratory therapists. The mortality from this disease in this state is about to skyrocket. This means we may not have a bed for you or your family member, COVID-19 or otherwise. Heart attacks, strokes, asthma. So if you break your leg skiing, whatever, we may not have a bed for you. So you may want to know how this is different from April. We are on a whole different logarithmic scale of hospitalizations. We also, at that point, were sheltering and we didn't have other medical care ongoing. And so we are actively walking back normal medical care right now. Our mistake was we didn't lock down long enough for tight enough, and we opened too early. You can see this on the curve. We opened society when we were here. If you look at Singapore, Korea, other places that, Australia that have their pandemic under control, you don't lift your foot off the brake here. The most expensive decision that can ever be made on the coronavirus. Can you imagine if I told you guys back in March, when we shut down the first time, 75% of businesses were open? Does that sound like shut down to you? No. What if I told you back in March, guess what? Hey guys, we're gonna sit down for 6 weeks and then we can reopen our economy. And then we can open restaurants, and then we can do this, and we're gonna wide brace test, and yes, you still have to wear masks, but we can reopen everything. Doesn't 6 weeks look like good news now compared to what we're facing now? 6 weeks we could have had this done. We didn't lock down tight enough or long enough, and we took our foot off the brake before we had the pandemic under control, and the pandemic was still ongoing here, and now we're heading into doomsday. So I don't want you guys to freak out about regular medical care. So back in March, when we didn't have universal masking and we didn't have tests, et cetera, at that point we were saying, okay, delay your testing, et cetera. Now that I've completely freaked you out about the hospital, I am not worried about you coming in for your angiogram or coming in for your echo or for your labs. We know how to do this now. We have masks, we space you guys out in the waiting room. I'm not worrying about you getting coronavirus coming in for your surveillance testing. And I want to emphasize that again. And I also, if you have something going on, you are going to sort of need to come in for that or be seen in a clinic. We know how to do this now. We got COVID-19 patients separated, we're not overcrowding, and don't skip it if it's important. I think if it's something that's super elective, we may want to wait till we're on the other side of that hump. So I get a lot of questions. Hey, Dr. Cogswell, can I X? I can't control what you guys are doing out there right now, but I want to emphasize that unless you know somebody has been in their house sitting still and has a negative swab after 2 weeks, they don't belong in your home right now. What can you do as Minnesotans? So even if Walls locks it down 100% right now, we are still, the die is cast on the next couple of weeks, and I don't think that's gonna happen. We have to do our part to control this. You going back to an April level of lockdown is going to save you and your family, and it's also going to save other Minnesotans from being overwhelmed. That is what you can do right now. And so the answer to all of these questions, maybe minus the work, is no. I saw my dad over the summer. We worked out this whole 2-week lockdown. He drove across. Absolutely nothing like that right now. All the roadways, the whole Midwest is teeming with virus right now, and it's only going to get worse. No airplanes. Everyone wants to have the kids for Thanksgiving. Don't do it. You've done hardship before. You can do it again. Spring is around the corner. We can do outdoor visiting then. That'll be much lower risk. Maybe we'll have the vaccine. We can get through this together. Be alive for the years to come and sit down now. No restaurants, no gyms, God forbid a wedding or a funeral. Guys, this is where everyone's mask comes off and everyone's embracing. These are super spreader events. And remember, we talked about the amount of virus you're going to get in your house with your family. That's where the highest risk stuff happens, guys, because the masks aren't on. Remember the amount of virus you get exposed to? Household contacts, not good. And you don't know what other people have been doing. People aren't that honest about that right now. And work, I understand you have to work. So if you can work from home, do it. More works are going to be transitioning to home. But if your work is having universal masking, distance, et cetera, taking those measures, I feel less worried about that. I'm much more worried about the kids coming for the holidays, you flying anywhere, anyone flying in or going to any of these other things. If you've got to work and it's a totally PPE situation, that's one thing. I understand you have to keep the lights on, but things that you can choose to do or not do, don't do it. Going to information, so cdc.gov, Minnesota Department of Health, New York Times, Covidcast is another thing that you can sort of look. This is a really cool website that looks at amount of masking, the amount of time people are leaving their homes, what the % positivity is in each county, and you can kind of watch the pandemic and you can Google that. So here are some places where you guys can go for information. So my central message, guys, is stay at home. Remember how we were in April? Go back. The time isn't 3 weeks from now, it's right now. You have a choice to make for Thanksgiving, and the answer is to sit down. Hand washing, masks. If the Department of Health calls you, listen and follow their instructions. I still want you guys to get medical care, and I realize you're all gonna call your coordinators freaking out after this. I just wanna let you guys know, I have canceled everything. My parents, nope, my parents are on lockdown in New Hampshire, where the prevalence is way less than it is here. There's no thought that I would have them drive across anywhere right now. No, no, no. We got to get on the other side of this thing, guys, and we are heading into the darkest days of this pandemic right now.
Okay, big stuff, big stuff. Everybody take a deep breath and then exhale, because you're okay where you are right now. Well, let me ask you a practical question on the do's and don'ts as we segue into the panel. I'll use myself to illustrate it, but it's something that I know there are people on this call that are also kind of in this decision process. By now, most likely, most everyone knows one person, two people, part of their family already has had coronavirus. And hopefully they've done okay and they're on the other side. Like, I'll illustrate with my example. My oldest son, 23 years old, his fiance live in Wisconsin. They both had coronavirus. They were both tested positive, had mild symptoms. They've been asymptomatic. Right now we're at the 2-week mark. Thanksgiving and Christmas are around the corner. Because they had it, now, there's judgment calls that start here, but I hope you know where I'm going is, do they have enough of an antibody load that they're not going to be transmitting? Is it safe to be in contact with someone like that, for some short amount of time? Is there any kind of guidance or suggestion other than a hard no?
Yeah, I can ask our infectious disease doctors about that. There is there have been reports of people getting a second infection. It's case reportable, so there's that. And then there's also the concept of the slightly different strain, whether or not the fact that they had the coronavirus, could they get a second strain and then give it to you? I think those are a little bit unknown answers right now. I think it's tempting to sort of think that if somebody's totally 2 weeks past or 10 days past and no longer transmitting live virus, that a gathering could be had. I need to find out a little bit more about vaccines. And again, I know what I know, but I'm also not an infectious disease or a virologist as well. And so these are some things that I can try to get the answers for.
Right, thank you. And with that, we'll segue into the rest of our panel. I forgot, Brooke, are you going next or is Diane?
Yes, I'm going next.
Great.
And then Glenn, I have to sign off and answer a few phone calls. I'll be back now that I've created all this holiday cheer. I'll be back. I'll be back right at about 20 minutes.
Yeah. You can just go mute if you need to on the screen. And,
okay.
And audio. Yeah.
Great. Well, I was also going to suggest taking a deep breath, so I'm glad that you did, Glenn. So thanks for that. So what my colleagues and I are going to transition to talking to is a little bit more specific to how to navigate some of the conversations that you will probably need to have now, if you haven't already, surrounding the holidays and kind of dealing with that process yourself, planning how to do it, and how to kind of rely on this resiliency that you've naturally developed and leaned on in the past. Because I know who I'm talking to, you have a lot of that already. So I'm going to jump in and kind of set us up for a little bit of what do we see going on in the psychological realm, and what's helping people get through these challenges, especially as we ramp up and the anxiety increases, and what are kind of some risk factors for when things aren't going well. My colleagues will take it next and kind of talk more about, here are some skills to use to have the conversations and some lessons learned from personal experiences. So I think the key things that I hope to take away is, for you to take away, would be, you are resilient. As humans, we are resilient, which means we overcome challenges. We have a natural capacity to do so. And in order to be resilient, we want you to feel empowered to do so. And I think I'm approaching this by, we want you to be knowledgeable about kind of what is the state of the struggle that other people are going through. It's okay to be stressed. It's okay to be worried and scared. It's natural. In fact, over half of the United States population is reporting some symptoms of depression and anxiety, and that is increasing. So we want you to have the knowledge. I want you to feel validated. And I want you to be able to kind of develop some additional ways to care for yourself as you go through this. Also, as we're thinking about the holidays, that would be a natural time, well, maybe not so natural. I was going to say a natural time for stress relief, right? Social support is so important to battle the effects of isolation. So you will probably feel more inclined than ever to reach out to your loved ones, to try and spend time together. And we're telling you not to do that. So that's going to be really challenging. And that's what my colleagues will address and create additional stress. So just to set things up, we are, in the world, we are stressed, and we are dealing with the effects of the infection itself, as well as the economic struggles in different ways. How we see the distress presenting most, when we ask people, like I said, about if they're experiencing distress, they're saying yes, that number is increasing. We're also seeing changes in health behaviors, so poor sleep. People are turning to substances to cope with the stress. In a survey of over 6,000 people, I think 12% of respondents, or 13% of respondents, said that they have started using a substance to cope with the stress. So people might even be developing new mental health or substance use disorders throughout this. We're also seeing increased reports to hotlines to report child abuse, neglect, and other things. So there's a lot of kind of struggles going on in that realm. We're also seeing a lot of delay of healthcare, avoidance of healthcare. So kind of trying to set that up to say, think there is stress, and here's how it's affecting people mentally and in their health behaviors. However, on the flip side of that, if I'm saying about, if there's 50% of people reporting symptoms, there's the other half who aren't reporting significant symptoms. What are they doing that's protecting them? What are they leaning on to kind of get through it? There is some lessons to be learned from that. So what we see, if we kind of tap into the psychological research from the past that we can apply to today, there's this concept of post-traumatic growth. It's very similar to the concept, the word I was using, resiliency. People go through traumas, unexpected traumas, where you're going through constant mini traumas right now, going through COVID as things constantly changing, and it's taxing our resources. However, there is a process that happens where people grow and people learn from it, and they kind of change in positive ways. And I think that's what we're hoping, if we kind of identify those as processes that are helpful for people, maybe you can look out for those in your own life and kind of integrate them as we go into the a harsher lockdown.
Hey, Brooke, let me illustrate that for everybody.
Please.
Everybody who's received an LVAD or had a transplant on this call is living proof of that theory. We've all gone through that trauma, gone through a major trauma, and we can all individually think about how did that positively affect us on the other end of it.
Yes.
Right?
Absolutely. And I think if I'm going to list the 5 domains where we see growth the most, and maybe you can relate that too. So we see it in change in appreciation of life, relating to others differently, appreciating their struggles more, developing new personal strengths, appreciating new possibilities that come from it, and spiritual growth. So those are the 5 ways that we see.
Yeah, as she described those, I don't know about you guys, but I know I could identify with every one of the 5 in my own personal life. And if you think about it, whether it's empathy, whether it's, identifying what's possible, or just being, thankful for what we have, that's kind of low-hanging fruit anymore.
Yes, definitely. Okay. So thinking about those strengths, and we want to kind of build it, you have those existing in your life. So how do we build upon them and lean on them now, kind of, is what we're saying. And this is kind of me, I'm going to transition to Diane. And again, like I said, we're going to feel pulled to be around people, and we're going to try to avoid that as much as we can. So here's kind of how to take care of yourself as you do that and remain isolated, as well as how to have those conversations. So Diane, I'll hand it off to you.
Thanks, Brooke. Diane, would you like me to bring your slides up now, or when would you like them?
I'll cue you. I
Okay.
put little notes in for myself. Thanks, Glenn. So I'm going to talk a little bit about how to structure conversations that you might have to have with family members and friends, how to plan for what you are probably not going to do, but even with the people that are in your safety zone, if you've navigated that already, how do you make these plans, and how do we keep ourselves capable of planning all that? So I'm going to be talking a little bit fast to try and keep my remarks in a particular time frame. My perspective on how to do this comes from a teacher that I know who, when people come to him with challenges and questions about how to keep their emotional balance, his name is Mark. What Mark typically says is, well, if this is the way that it is now, and it seems that this is the way it is now, how can you make now the best that it can be? So the components of how he lays that out: recognition, oh, is this the way it is now? And then acceptance, oh, it seems like this is the way it is now. Acceptance doesn't mean you agree with it, doesn't mean you think it's a good thing. And I think we get confused about that a lot, because we say, well, if I accept it, it means that I think it's okay. No, it just means that that's the way it is, and we can't change that. And it's kind of like the weather, it snowed yesterday. I didn't want it to, but I accept the fact that it did, so I better put on my boots and my warm clothes. And then the third part of the way that he approaches challenges is problem solving and moving forward. So what can I do? What can I do to make things better? And there's several components to that. A lot of it involves getting more information. And we just got from Dr. Cogswell the information that we really need, the critical information about what our risks are. We're going to try and give you a little bit more information about communication tools that will be helpful, and then information about how to keep our own emotional balance so that we can do all of this. And going back to what Brooke said and what Glenn said earlier, breathing. And I just this morning came across a fabulous article that I may add to our resource list, Glenn, about the scientific data behind why breathing is helpful. Why does everybody say take a breath? It actually affects our neurochemical balance in our brain. It decreases our cortisol load. Cortisol is what makes us have the fight or flight or freeze reaction. And if we are going to make good decisions and make good plans, we need to decrease our cortisol load so that we can use our prefrontal cortex to make good decisions. So first slide, please. On this slide, you will see lots of lovely things that you can do to reduce stress and get your own emotional balance. And I want you to pay, no, that's the last one, Glenn.
Yep, there we go.
There we go, the first one, please. The one with the rocks.
Yep.
Yeah.
There we go.
There
Sorry.
we go. So number one, I think is the most, although I think every single one of these points is really, really important and really helpful and contains a lot that I could talk about for a long time. Focus on number one, focus on what you can control. For those of you who are familiar with it, this is all about the Serenity Prayer. There are things that we can control, things we cannot control, and we have to use our wisdom to choose to put our energy on the things that will more productively lead to the outcome that we want. So I want you to keep in mind, first of all, this is not forever. This is not World War II. This is not 4 or 5 years of rationing and Liberty Gardens and those things, for those of you who are old enough to have some memory of those. It is one holiday season, and I don't want to minimize how hard it's going to be. This is going to be hard. It's hard not to do the things that bring us joy every year. It's hard not to do the things that we look forward to every year. It might even be really hard not to do some of the things that we dread every year at the holidays. It's going to be hard, and we still have to do it, and we can. You know that you have the ability to get through things that are really, really hard if they're important enough to you, because you already have those experiences. So how do we figure it out this time? Because this really came kind of surging, to use that word, out of nowhere. I think what I want to ask us to start with is an essential focus on compassion and kindness as we go into these conversations, when we have to tell people that we love that we may not be able to see them. And we have to have the ability, and I say this to you as a native Minnesotan who was born and raised here, we have to let go of Minnesota nice. We have to let go of our aversion to conflict, our aversion to awkward and uncomfortable conversations. We have to be willing to ask direct questions and to give direct information. And that's the only way that we will know if the people that we want to spend time with are safe for us to spend time with. It will be more uncomfortable, as Dr. Cogswell pointed out, to deal with the emotional reactions that we may have if we don't have those conversations, if people get ill. So we have to plan and discuss ahead as much as we can, as early as we can, and lead with clarity and compassion. Go into these conversations, if you can, the best you can, without a sense of us and them. We're all trying to figure out how to do this the best that we can. And sometimes it can be helpful to remind people that the reason you're asking questions is that you want to make sure that you are not putting them at greater risk. There may often be the assumption that we're asking questions because we think they're not safe, whereas we may actually be wanting to protect them. And keep in mind, again, as Dr. Cogswell has said, everything that we're talking about today is based on what we know today, and that's going to change. So some of the resources in the list that you will have access to are already outdated. For example, a tool that I think can be really helpful to use is a list of activities from least risky to most risky. However, that changes as we get more information. So you'll find in the resource list, in one of the articles, there's embedded one of those lists from least to most risky. It's out of date, but it provides a model for how you might develop that kind of list so that you can use it within conversations and say, my family and I don't do any activities that are above a 2 on this list. What does your family do? That can be helpful. And then when you're having the conversations, give information about why these boundaries and guidelines are important to you. What about it is aligned with your values? Why are you asking people to make these sacrifices? That goes a long way for a lot of people in being able to hear better what you are saying, being able to listen to hard things like, no, you can't come home for Thanksgiving or Christmas. And then the final piece is about a very overused term, but it's really important, self-care. It's about you taking care of yourselves. Second one, please, Glenn, the isolation well-being list. So this is a list that I actually got access to because Glenn found it. It is one way of developing for yourself a routine. Routine is really, really critical to maintaining our emotional balance. I know that when I get up in the morning, I have several things that I do, and on days when something pulls me away from doing those things, my day doesn't feel right. There's something that's off. Developing a routine can be really essential. And then, sorry, I lost my train. All of the other things, I encourage you to spend time with this list. It is on that resource list. There will be a link to it. All of these things that keep us connected with our hearts, with our spirits, with other people, with those who can be helpful to us. And I think the way that I will choose to segue to Jane is to say that these ideas allow you to open up your creativity. And that's one of the things that I know that she's going to be talking about and how helpful it can be within this. So that was very brief. There's a lot of information that you will have access to, and hope that just this short summary has been a good review.
Thanks, Diane. And, you know, I'll confess, those that know me, whether from support group or wherever, there's my list, and it's on my refrigerator. So it's been in practice for 6 months now. And anyway, so it works. Anyway, on that note, okay, we'll shift it over to Jane. Go ahead.
Okay. Thanks, everybody. I'm delighted to be here today. One of the pieces that I took from Transplant was a strong desire to give back. And I hope that by participating on this panel, I can share my story, our family story, and in some way provide some of the rationale that's and some of the comfort measures that have sustained us in the last months. When I first started making comparisons between COVID and transplant, it must have been about 2 months into the lockdown or 6 weeks or whatever, anyway, into the whole COVID experience, and a number of words came to mind. Excuse me. One of them was path. One of them was navigation, which we've talked about in terms of how we've been dealing with COVID. And I also looked back and remembered kind of the emotional side of transplant, and fear and loss came to mind. So to just kind of look at the path and the navigation piece, I think what I started to remember is that, yes, we're navigating a path, and there are very, very many things that we cannot change. Dr. Cogswell referred to all of those. I don't have to repeat those, but there are some things that we can take into or be empowered by. And we've learned those today too. I can become informed. I can learn. I don't have to rely completely on fear. I can become informed with the knowledge that's out there, and I can choose to be safe, and I can choose to encourage others to be safe. And we've already learned today about the impact if we choose to be safe. I can't control if I'm going to get a vaccine, when a vaccine is going to be available. I can't choose when COVID will end or predict that. And I can't necessarily change the behaviors of others who choose to be unsafe. I can be an example and I can be assertive, but that might not make a big difference. The second kind of cluster of words that I already referred to that kind of pop back into my mind with regard to COVID. Again, or loss and fear. Loss of, when in experiencing transplant, loss of health and functional abilities, loss of routine, loss of predictability, financial challenges. And for our family especially, we're very close knit, and a loss of traditions and celebrations, how we normally gather and the kinds of activities that we do. My son was in the hospital for 9 months. And so we, over a very extended period of time, had to kind of do a lot of shifting and accommodating to remain close. And that was one of the real gifts that we took away from transplant, is that we learned to do a lot of things differently, and we still do them that way. The fear was fear of the unknown. How long will we wait? Will Matt's condition get worse? Will something make him not a candidate for transplant? Will there be complications? Will my family be okay? Will we be able to weather the storm? And we did. And in this loss and grief kind of perspective, I was reminded by an expert in grief and loss, and he actually identified another stage of loss and grieving, and he called it finding meaning. And I thought to myself, okay, I was able to find a lot of meaning in transplant. What's the challenge here in terms of COVID? What's the meaning part going to be in this experience? And I looked back on transplant, and I think that I've used some of these pieces that I learned back then to apply to COVID, and maybe some other challenges that I've encountered along the way. The first was to be curious. What can I learn? What can I learn from this experience? I haven't done this before. I hope I never have to do it again, but what can I learn? And really slowing things down to be able to explore that in some detail. What will I continue to do differently? There may be some things that we learned from COVID that maybe aren't so bad, that we can duplicate in our everyday life once we move past this. How will I give back? If you do experience COVID and you find some meaning in that experience, and you find some level of resiliency that you can share with others when they're experiencing difficulties, that might be one way. And what will help me today? That was a big one for me. I'm not the kind of person who normally pays attention to my own needs, but I did during transplant, and it really sustained me. I thought, you know, what'll get me through today? And I bought myself a lot of flowers, which was one very proactive step for me. And I learned to slow down. I learned to try and take into account what I could be, especially be grateful for. And that's the second piece of how I think our family navigated COVID. When we started navigated transplant, I think when we started feeling anxious and restless and hopeless and all of those other negative feelings, we looked around us and we saw the University of Minnesota in our backyard. It took us an hour to get there, to visit Matt, to be surrounded by caring, compassionate professionals who knew more about transplant than anybody, and to be really grateful for those relationships that we formed, but also for that expertise and that compassion. We were most grateful. The technology, another piece to be very grateful for. I was a nurse for 35 years, and I worked specifically in cardiology and clinical and management roles. So I had watched cardiology evolve a lot over the years. And when I looked back and remembered what I knew of cardiology as a nursing student and where it was when Matt was in the hospital waiting for transplant, it was just incredible, just absolutely an amazing comparison that made me very, very grateful. Family and friends, got us through. Our faith, our spirituality, our faith traditions got us through. We were very grateful for those things. And I think maybe one of the, I hesitate to say fun pieces, but maybe one of the most memorable pieces was our creativity. We carved pumpkins, we dyed Easter eggs, we had an Easter buffet, we did all kinds of things that we normally would be doing in our own home. We did them in the hospital. And I think probably one of the best memories for our family is this. My husband and I attended a conference every summer on Mackinac Island, and it's a cardiology conference. And one of the things this location is known for is their 5-course dinners every night, and you dress up, and it's very prim and proper. And we started bringing our kids when they were fairly young. And if they had to choose between Christmas and this trip, they would choose this trip. Well, guess what? We didn't go the year that Matt was in the hospital. And we knew we weren't going, but as a family, we rallied together and we used the conference room, and we used china, crystal, linen tablecloths. We duplicated the menu along with the logo from the restaurant that we normally ate in. We had orchestra music from the same group that plays in the dining room. We had it on DVD. We even had a picture of the dining room up on the screen for us to look at while we were having dinner. And we dressed up. We brought Matt a suit and said, "You're dressing up." We didn't tell him where we were going, and we celebrated that dinner in a very, very special way. So creativity, gratitude, and being curious were the things that got us through transplant. And so far, they've worked pretty well for COVID. The facts are very, very daunting, and the unknowns are unbelievable. But we do have some resources within ourselves to get through each day and to learn how to sustain ourselves and others.
Thanks, Jane. You know, an illustration of creativity, for those might have seen Monday's Star Tribune, had a nice article about how to do a Zoom Thanksgiving. And we may include that in our links afterwards as well. So there's some creative ways where you don't have to actually sit and watch someone eat. I don't know that we want to do that, but you're certainly welcome to any version of a Zoom Thanksgiving you might want, but it offered some fun ideas. With that, I think we're going to shift over to kind of Q&A section. I know we've got some questions that come in the chat. You're welcome to post them there. You're welcome to post them in the Q&A itself. And go ahead, you know, anything for any of the panelists at this point. While we're waiting for a few of those, I want to offer a question. Probably, you know, well, probably Dr. Cogswell, but anyone can chime in. This idea of going back to April, this idea of clamping, I'll call it clamp, we clamp down on ourselves to be super safe. You know, for a person like me that lives, you know, in a city or, you know, in the near metropolitan area, you know, we can rely on Instacart or some of the delivery services to stay out of the grocery store, stay out of the Walmarts. What about those in the rural settings? Because we know, you know, transmission is occurring in rural settings. Are there any suggestions or ideas, understanding that anyone in your household that might go is as if you went as an individual? So does anyone have any thoughts on that?
Yeah, and I also, a couple of follow-up things, I'll come to that. I did, so the Pfizer vaccine, just to follow up on that, it's an mRNA vaccine. It's like a first of its kind. It's not a live vaccine, but I still think the answer of what we're going to do from a safety perspective, when it's only been tested in healthy volunteers, how we're going to roll that out. It might be that transplant patients get the benefit of the vaccine when everyone else gets it. I don't know the answer to that, but it's not a live vaccine. And then I just also, on the question of whether you can be around people who have recovered from the coronavirus, you know, we're just not sure how long immunity lasts. And so presume that it only lasts 3 months, which would be catastrophic. We're hoping it lasts longer than that. And somebody gets the virus again, or perhaps a second strain, and then you're around them assuming that you're safe. That might just not be safe. I think we just don't know the answer to that. And I also just wanted to sort of, I know there was a lot of kind of deep breathing after I spoke, and I think part of the reason I'm coming down a little hard on this right now is I've got my own fears about keeping you guys safe. And I also think, first off, I'm, as well as a number of physicians, actually scared about what's happening in the hospital and where this is going and how we're going to be able to handle it. And I feel like that news is not making it into the mainstream media. And I feel like it's my responsibility to give you the truth so that you can make the decisions that you need. And it's not to scare you into not being able to sleep for the next couple of nights. It's literally because I care about you guys and I need you to understand sort of where this is at. And I'm sorry if that came off sort of like harsh in reality check and overwhelming, but each one of you that starts to get infected, like my fear goes up to here that something awful is going to happen. And you guys have already had awful things happen, you know? Like, thank you, Jane, for sharing your story, like how hard that was. And, you know, for someone to get sick in your family now would just be like a tragedy that we could have avoided. To answer your question about the, you know, I do think from where we were in April about really understanding how the virus is transmitted, is it off of surfaces, is it aerosolized, or is it only in respiratory droplets and all this stuff, I really do think that, you know, if you're in a grocery store environment briefly at a not crowded part of the day where every person is masked, that to me is 100% better than going to somebody's home or inviting people into your home without masks off for dinner, or going to a wedding or a funeral, or God forbid, going to dinner for an hour where transmission is documented over and over and over again. And so the idea of, and yes, you can have things delivered, but I think of the worry is in places like South Dakota and North Dakota, where I'm having a Sioux Falls clinic today. They've all got it. With the first patient this morning lost her brother. He's 50 years old. My first patient this morning actually has it right now. Like, it's just everywhere. And so I think in those settings where the community prevalence is so incredibly high, having the food delivery, we are not thinking that the coronavirus lives particularly long on surfaces, or that, you know, I'm not wiping down. In the beginning, when we didn't really know, we were all like wiping down all of our groceries and things like that. I don't really know that that's necessary. I think the idea that you're going to sort of get it from a surface and like put it into your nose, we're thinking it's much more particles sort of in the air that are happening. So I don't know if that's answering your question, but I think in general, if you need to go to the grocery store and everyone's masked there, but in some rural communities, not everyone may be masked, in which case the delivery service may be better.
Yeah, well, where they have it available, and there's been a couple of questions come in too, and certainly one before about, you know, well, what about, you know, in some of those environments where there's little to no masking, or there's questionable masking, you know, one of the favorite is to wear the mask down.
Oh yeah, then down on the nose, yes.
Yeah, yeah.
Everyone's favorite. Yeah, that's not the way that the mask should be worn. We have to reemphasize that.
Yeah.
The other thing is if you think that somebody in your house has been exposed, and this is just a real practical consideration, this happens. There is a recent study showing that, which is really not fun to do, but masking up of everyone in the household. Obviously, you can quarantine that person away, but if you're awaiting test results and it's kind of a lower probability exposure, masking up in the house can prevent transmission through the house quite effectively. Nobody wants to do this. This is the least fun thing for all of us who have kind of experienced now, where somebody may have been exposed by somebody, you're not sure, it's going to take 4 days to get the result. But if you think that somebody you're waiting for test results, or first off, if someone's got symptoms, they need to be in a separate part of the house on lockdown, away from everyone else. But if you're a sort of in between probability, masking, you know, individuals in the house can help. The other thing I want to emphasize too is there's this general concept of, oh my goodness, I've been exposed, I need to go get a test right now. This is not how the coronavirus works. Typically after exposure, it takes it can be as quickly as a day, but as late as 14 days before symptoms arise, if they're going to happen at all. Remember, people can have asymptomatic infection as well. And, you know, we can't really start detecting virus until 3 or more days after exposure. And so the idea that, my goodness, I just got a call, I was out to lunch with somebody and they got tested and they have it, that you're going to go run out and go get a test and somehow have that be reflective is very inaccurate. I'm sure that's yielding a lot more questions, but that leads to a lot of false reassurance.
Yeah, right. One question, you know, and I guess it's a bit of a Minnesota thing when we think of grassroots here in Minnesota. Is there a place where you could point folks if they want to, you know, help spread the word? Other than, a lot of what we're talking about today is, the holidays, our immediate family, and I think that's where we can actively, help ourselves and help our loved ones by sharing this information with them in an appropriate way. But even more like it's say a local government level or a state level, that I know the healthcare system is doing its part, and folks like yourselves certainly, but are things that could help empower folks that might have in the call to help the cause?
Yeah, I mean, I think if you guys want to, put onto Facebook or Twitter, Stay Home Minnesota through the holidays, I mean, all anyone has to do is look at the hospitalization curve and know that the holidays are coming, to know that that the hospitals are literally exploding with virus right now, to know that we're in a big problem spot. And so if you guys want to take it among yourselves, I have been talking to Michael Ulsterholm, Glenn knows that. And I've been in communication with the governor through the dean, trying to spread this information. I sent emails to the health commissioner this weekend. We're kind of weighing out an open letter in the Star Tribune to patients and just to community, just to Minnesotans. I think if we can even get a certain percentage of families to cancel their plans and to stay, every time we do that, Minnesotans' lives will be saved. It's that dire. Once again, I go panicking you all again, but absolutely spread the word. Spread the word that we are on the brink. We are right on the brink of Thanksgiving. This is not the time to get COVID fatigue. We've got hunker down Minnesota, stay home Minnesota. Spring is going to be here before you know it, where we know outdoors is an easier, more safe way to be able to congregate and be together. We just experienced that this summer. This is a very dangerous time to be gathering. Stay home Minnesota. Absolutely.
Good message. Joel has a great question. Of course, it's Joel, so it's a great question. Let's talk practical for a transplant patient. And this would be for LVAD too. So let's say that we suspect we might have it, we might need a test. Point of contact, our primary care provider, general physician, our transplant coordinator. That's step one. And then step two is, okay, let's say a transplant patient in particular, or LVAD could be, comes down and becomes symptomatic and so forth. What are they looking like, having treated some of these now? And by the way, I'll say this based on bed availability, and then you might want to answer it without availability as well. What's the progression there for care?
Yeah, so typically we want you to let your LVAD coordinator or transplant coordinator know. All community clinics are getting inundated with these calls. I think before you go and get the nasal swab, you really want to be sure that the turnaround time, Walls is working really hard to make testing, broadly available. Part of getting a hold of the whole pandemic is really having enough tests to isolate the people who actually have the disease. And, but what you don't want to do, just from the practical perspective, is go to some place where the turnaround time of the test is 4 or more days. That is really awful for families and really awful just to practically be masked that entire time. You want to get the PCR test. There are rapid antigen tests that are advertised now. They're a little bit better at performing when patients actually have symptoms. They're very bad at ruling things out. But there are PCR tests, which is the test that you want, that are available literally in under 24 hours. And so the first thing is to confirm the diagnosis. Your transplant or LVAD coordinator or a primary care physician can direct you to a site that's going to have pretty rapid turnaround. Then typically we are, for patients who are quite short of breath at that moment, we usually call ahead to the ER so that they know that they're coming to be seen. This is a good time to invest in a home pulse oximetry monitor. We know that with this disease, patients can be very, very low oxygen saturation without really knowing it. And so it's very, it's reassuring to us. One of the patients I just got off the phone with this morning who has a VAD in South Dakota, is checking oxygen levels, every day, several times a day. And I think that's not a bad thing to get online if you don't already have one. If you have shortness of breath, like legit shortness of breath, you need to be seen. And in general, we would prefer you guys either with LVADs or transplants to come to university, but this is also, yeah, so Gina's asking, can he come home? I don't know that we know the answer to that based on my research. He could have another strain or get reinfected. So, all right, what else I was going to tell you guys? Yeah, so you just
So the progression.
never know, because we are typically checking if for our patients who have COVID, symptoms, we're trying to make sure that they're letting their coordinators know if they're worsening so that we can get them to the right spot. We are trying to prioritize patients who have COVID and have an LVAD or a transplant to be at the university, but we're rapidly going to not really have the luxury of being able to do that.
Okay. Got it. Important. Other questions out there? We've got a little bit of time left for anyone else who might have something. This is a bit on the fly, but I'm going to put Diane on the spot. To counterbalance to Cogswell's facts and figures, and well, I'm going to use your word, scaring the crap out of us, appropriately so. What thoughts about this? Knowing that many in our population and how we collectively kind of take in this kind of information. What can we do? Have any reflection on that?
So going back to where I started, what Dr. Cogswell has just shared with us is that's the way it is right now. So if this is the way it is right now, and it seems like that's the way it is right now, what can we do? What is each one of us capable of doing to make sure that we make now the best that it can be? And I think Jane gave us some beautiful guidelines to start with. Curiosity. Okay, so I can't do Thanksgiving and Christmas the way that I have been hoping, imagining, wishing that I would be able to do despite the pandemic. So what are the options for how to do it? And then we go to the creativity. And there's all different kinds of ways to do it. And yet, Jane's middle point, gratitude and compassion are what are going to get us through. And focusing every day. I learned this from a young woman that I saw many, many years ago who had gone through being the support person for her husband while he was getting some really, really significant treatment that had all kinds of bad consequences and affected both of them. And she came back to see me after he had gotten through his treatment. He was doing great. She was doing great. About a year and a half later, she came back and she said, I need a tune-up. My depression's coming back. And I asked her, how did she know? What gave her the information? She had developed the practice of doing essentially a gratitude list every night. And this was before Oprah made it famous. So every night she had a little notebook where she would write the date on top. And every day she would write down 3 good things, or was it 5? No, it was only 3 good things that had happened today. That was her 3 good things practice. And she wasn't talking about the big things like I won the lottery or I got a huge promotion. She would write down the little beautiful things that she had allowed herself to see every day. The cardinal that flew past while she was at the window washing dishes, or the lights reflecting off the buildings downtown when she walked to work at lunchtime. And when she got to a place where 3 days in a row, she couldn't come up with those 3 good things that had happened today, she said, oh, I must be getting depressed again. And that's when she left me a message. Gratitude can be something that feeds our spirit, that feeds our emotional well-being. And it can also be a great, I think maybe a thermometer of how we're doing if we can't find the gratitude, if we realize that we have shut down and we're not seeing those beautiful things like, oh my gosh, did you see that full moon last night? When we miss all those things that we typically see, we're kind of curling in on ourselves and not allowing ourselves to reach out and be connected with the world. So gratitude and compassion. What is compassion actually? Compassion is simply the reaction that we have when we observe suffering and we have a reaction of wanting to reduce that suffering. So if we go into this situation with compassion for ourselves, compassion for each other, wanting to reduce the suffering, wanting to find ways to connect and find those little moments of joy, I think that's the way that we will get through all this. And Glenn, maybe now you could put up that third slide, which some people may notice that it sits behind me over there, and it's from Mr. Rogers, and it's just about kindness, that there are 3 ways to succeed. The first way is to be kind. The second way is to be kind. And the third way is to be kind. And if we go into this with the desire to be kind to ourselves, which means taking care of ourselves, and to be kind to everyone else, which means taking care of them too. And with Jane's guidelines of curiosity, gratitude, and creativity, I think we'll come out okay.
Wow, what a closer.
That's why I wanted to.
Yeah, thank you. I'd be remiss, we've got another question that we want to get answered, though, in the meantime. And
the rehab.
While we're here. Rehab, cardiac rehab.
Yeah, I think, Tim, depending if every person, it is hard to exercise with a mask on. If there are not masks being universally used in this cardiac rehab, I would favor maybe doing if you have the equipment at home, using it, but that does not mean you don't get to use the equipment. I need you working as hard at home as you would there. But I'm getting increasingly worried as the percent positivity in the region skyrockets about the safety of being in any kind of gym setting, cardiac rehab. And cardiac rehab is doing a really good job trying to stay open because it's such an important service for our patients. But if masks are off and it's people who have been in healthcare settings and it's a bit crowded together, I don't know how safe that would be. And I also just want to say to everyone, you guys blame me. Blame Dr. Cogswell. 100%. This is my fault. But also you can be proud of being, whether it's North Dakota, South Dakota, Minnesota, anyone tuning in here, your decision, this is a call to action. By action, I mean not, you are saving other people and yourselves, not just you, by making the choices that you're going to make in the next month and a half.
Yeah. I can add some real experience on rehab. For those that don't know, I in addition to heart, and had a few other organ issues. I just completed pulmonary rehab, which is identical to cardiac rehab as far as in there. In the Fairview rehab, and specifically, I was at Riverside, and I know they have the same policy at the other locations in Burnsville as well as in Southdale. So they're very strict on the number of people that are exercising and participating. Everyone wears masks, period. Even while exercising, they will allow you to pull it down and breathe through your nose if you have to. I'll tell you what, gang, I have 40% lung capacity. I had my 3-ply mask on the whole time and never needed to move it down. So there's a challenge for you.
Yeah, so I think if that's the setting where that's the expectation, et cetera, and they're, screening people, et cetera, I think that makes me feel better about it. But if we head into, December, where the curve continues and we haven't seen the other side of it, we may have to reevaluate. And we're reevaluating on the inpatient side, procedures, visitors, everything's on the table. And Walls is kind of weighing this every single day about how much to try to lock down here.
Yeah, great. Any closing comment? I think we've got all the questions at this point. One thing I will add to note, this has been recorded, and it will be posted by the end of the week, along with the recommended links and slides. So I know several of you are interested in that to review. So for those of you that missed the beginning, that'll be there for you. And obviously you can share that with your friends and loved ones. So we'll have it on our website by the end of this week. So you'll see it under our COVID-19 panel with the previous information. So, one quick question, good one, Fran. Dr. Cogswell, what's a good pulse oximeter to have? And while you do that, I'm going to show an example.
I think any. I don't know that there's one but better than the other. They're actually sometimes on back order at this moment. So I think if you get one that's got good Amazon, we got ours on Amazon, it seems to work just fine. There we go. Yeah, I mean, get the one that Glen's got, but honestly, a lot of them are out of stock right now. And so I think, you know, if it's got good Amazon ratings, it's not like there's one in particular, they're all pretty effective.
Okay. By the way, I picked mine up at CVS, in Walgreens, that type of thing.
Yeah,
she actually needs a reading. So do you want to give, you know, if it drops below X, you should be worried? I mean,
yeah, I think if you, I think for sure, 100%, if you're high 80 anything, you get your butt in ASAP. I think if you're kind of high 90s and you're finding it harder to breathe and you're heading into the low 90s, you're noticing it going down, you should start to call your coordinator and see whether you should come in. But for sure, if it's anything high 80s at all, this is definite go button, you need steroids.
Okay, great. Okay, well, thank you all again. Thanks for audience joining today. Really great information. Wow, could I ask for a return visit down the road when we're talking about, you know, when we're all going to get the vaccine or something like that, hopefully?
Oh, sorry. I'm getting text messages for some people telling me how freaked out they are after this talk. So I'm sorry in advance. So a return visit. So you want to do another interval, like in the early. Yeah, you need to return at any point to give you guys information in real time of what's going on. And we could play that by ear. We could do something, you know, by mid-end December. I'm hoping that the curve, I honestly don't see the curve turning without us fully scaling back or Minnesotans sitting down. So, you know, I mean, at any point, if people are wanting sort of updates of what's going on in the hospital, we could do a late December, early January, if there's some big vaccine updates, or we could do, you know, I'll leave it up to you guys in terms of when you're wanting more information. People may not want to hear this after this one. Glenn, you might have to take a poll.
Well, we might have some good information to talk about. So if in an appropriate time, we'll be in touch and we'll figure it out. Yeah. So anyway, thank you all. Again, thanks to the panel. And for those of you, you know, don't forget to register for our holiday party. So we got creative and we took our annual holiday party, and it's on Zoom. And we will pre-announce one of our special guests because she told me she would attend, and that's Dr. Cogswell. So she may have already forgotten that she said yes, she would attend.
No,
so,
I remember. But the mood will be lighter. If it's actually a party, we're not going to talk about doomsday, right? We're gonna have our you know, I don't know, signature cocktails or something. Yep.
Yes. Yeah. So hats. You know, feel free to decorate your backgrounds. You know, yes, and we're going to celebrate transplant anniversaries, LVADs, and a few other things. So,
and I promise not to scare you.
Yeah.
I'll put on my fun hat.
All right. Thank you all again. Have a great day.